Good afternoon. I'm Professor Jin Young-kwak from Yonsei College of Medicine, Severance Hospital, South Korea. I will be reviewing the Korean thyroid and its role in the ultrasound classification of thyroid nodules. Today, I will talk to you about the following. In 2011, the Korean Society of Thyroid Radiology published its first recommendations. In 2016, our group revised the ultrasound risk stratification system for thyroid nodules, developing the Korean thyroid. Korean thyroid is based on a huge amount of published evidence and consensus between experts. Our system is pattern-based like the ATA and EU thyroids. Including negative imaging, it is a 5-tier system. In Korean thyroids, a solid hypoechoic nodule with suspicious ultrasound features is categorized as high suspicion. In these images, we can see solid and hypoechoic nodules with microcalcifications, bicolobulated margin, and taller than wide shape. Two different criteria can define intermediate suspicion nodules. One is for nodules that are solid and hypoechoic without any suspicious ultrasound features, just like these nodules in here. The other is for nodules that are not solid or hyper to isoechoic with suspicious ultrasound features, like these with microcalcifications. Low suspicion nodules are defined as partially cystic or hyper to isoechoic without any suspicious ultrasound features. These nodules are benign. We do not recommend FNA for any of these, except for the spongiform nodule. In my talk, I'm going to give a short and simple comparison of four thyroids. This is just a brief overview because I can compare all the details of each system in just one session. Also, I'm afraid that if I do try to squeeze a detailed comparison within the limited time, it will actually create confusion. The ACL categorizes nodules by adding up score points assigned to each ultrasound feature. The other thyroids use the pattern approach. Let me show you several images for these four different thyroids. FNA is recommended for high suspicious nodules equal to or larger than 10 mm according to the four thyroids. However, the recommended risk of malignancy varies according to the type of thyroids used. These ultrasound images are from published papers on thyroids. The suspicious ultrasound patterns presented by the three systems are almost the same. In ACR, a score of 7 points or more classifies nodules into the high suspicious category. If we refer to research by Middleton et al., the number of ultrasound lexicon combinations for this category is 51 in total. Of these, 43 combinations show similar ultrasound findings with the pattern-based thyroids. In others of the intermediate or moderately suspicious category, FNA is recommended for nodules that are equal to or larger than 10 mm according to the ATA and Korean thyroid, and equal to or larger than 15 mm according to the ACR and EU thyroid. As you can see, these nodules are similar in shape, but these were classified as high suspicion with the ATA and the EU thyroid. Using ultrasound lexicon combinations, just half of the nodules in this category of the ACR thyroid have similar ultrasound features with the Korean thyroid. Nodules of the low or mildly suspicious category are also recommended for FNA if they are equal to or larger than 15 mm according to the ATA and Korean thyroid, larger than 20 mm according to the EU thyroid, and equal to or larger than 25 mm according to the ACR thyroid. All three pattern-based thyroids demonstrated similar ultrasound features. The ACR thyroid is also similar to the pattern-based thyroid. When we reviewed the four thyroids, we observed similar ultrasound categorization in many cases, except for the intermediate suspicious nodules. Other ultrasound risk stratification systems, such as the 2002 Kim thyroid and the most recent Chinese thyroids, have also been developed. There are constant efforts to develop better thyroids. Until now, most studies compared the indicators of diagnostic performances with varying results. Research on the diagnostic performances of these systems has largely been done in two ways. One approach is to compare the performance of ultrasound risk stratification systems only, and the other is to compare performances when the FNA size threshold is considered with the ultrasound risk stratification systems to determine which nodules should undergo FNA. When only the ultrasound risk stratification systems were compared, most studies found that the different thyroids still showed similar AUC values. Many factors affect ultrasound examinations. One weakness of visual interpretation is reproducibility, which is an inherent limitation of ultrasound that cannot be avoided. As we can see in this study, inter or intra-observer agreements were not good, and the kappa values for the agreements were even mostly 0.5 or less. In this study, even with consensus being reached between the readers, the kappa values were mostly 0.6 or less. So, radiomics and artificial intelligence started to be discussed as alternatives because they are more objective than visual interpretation. In this paper from China, the diagnostic performance of artificial intelligence was similar to that of radiologists. The categorization done by artificial intelligence was found satisfactorily in our hospital as well. There are studies that compare tallies by considering the ultrasound risk stratification system and size threshold together to determine whether nodules should undergo FNA or not. These graphs evaluated accuracy and the unnecessary biopsy rate according to the size thresholds of the tallies themselves. If you see here, the ACR tallies showed better accuracy than the ATA or the Korean tallies, and even had a lower unnecessary biopsy rate. Accuracy increased when the ultrasound risk stratification system of the ATA or Korean tallies was used with the size threshold of the ACR tallies compared to the original tallies. The unnecessary biopsy rate also decreased. The study on the right with the ACR, QA, the ATA, and the EU tallies also showed similar results. Therefore, we can assume that the diagnostic accuracy and unnecessary biopsy rate were affected more by the size threshold than the ultrasound risk stratification system. With so many published tallies and one-suite publication arrangement, how can we choose which one is the best? Some studies have included more elaborate but complex ultrasound features, and other studies have shown that additional ultrasound techniques can improve diagnostic performance. Now, is it really beneficial to try to develop more complex and diverse techniques for an international tallies? I think the comment of Dr. Alexander can answer these questions. The fact that organizations publish newer systems for the management of nodules without replacing earlier versions may undermine their general acceptance. Maybe organizations should address guideline quality and implementation barriers rather than publishing multiple versions. For example, with the BIRAs, the prototype of the structured reporting system has remained intact through revisions. We need that for tallies to help users trust and continue to use the system. The most important factor that has to be considered when developing a practical international tallies is who is performing the thyroid ultrasound. While we haven't collected data on a global scale, we can assume that many performers will not have that much experience with thyroid ultrasound. Also, artificial intelligence might help overcome the subjectivity of ultrasound with diagnostic performances comparable to those of experienced radiologists. Shortly, I'm going to show how artificial intelligence can be applied in clinical practice. My team in South Korea developed an application to diagnose thyroid nodules. We named it Sarah. Artificial intelligence using the convolutional neural network provides cancer probability from 0 to 100%. We can divide all nodules into categories according to the cancer probabilities presented by artificial intelligence based on each talase. As you can see, Sarah can display malignancy risk and indicate whether FNA should be performed according to different tallies. If the performing endocrinologist has a little clinical experience with thyroid ultrasound, artificial intelligence can help improve diagnostic performances for thyroid nodules. Recommended risk of malignancy is an important component of tallase. It can be a medical audit standard for physicians who interpret nodules on ultrasound. For an international tallase, the choice of size threshold is very important because the right choice helps us reduce overdiagnosis and overtreatment. As you know, FNA is not a universal solution and can actually create new problems for thyroid nodules. That is, FNA can result in indeterminate reports for about one-third of cytologies. The Korean College recommends follow-up strategies based on ultrasound and FNA results. This nodule is a 24 mm with benign cytology. Serial ultrasound was not recommended by the ACR and EU tallase. In contrast, the ATA and Korean tallase recommend ultrasound follow-up. The second example is of a 6 mm suspicious nodule in a 59-year-old male. One great strength of the ACL tallase is that it gives you concrete guidelines on when no action can be done. Sometimes not doing anything is what is best for the patient. As I have shown you, Koreans have access to a wonderful tallase. But does this system work well in actual practice here in South Korea? Two recent studies wanted to see if they did. In the first study, about 77% patients with micronodules were referred for thyroid nodule biopsy. The second study demonstrated that about 35% patients who had micronodules aspirated from outside clinics were referred for thyroid surgery. Therefore, we needed to develop an international tallase that allows greater adoption and behavioral changes in clinical practice. Now, I am going to end this session after presenting two cases. This woman's first ultrasound shows a nodule with an echogenic line. Her follow-up ultrasound shows an increased nodule with internal echogenic spots. The patient underwent FNA and her cytologic result was non-diagnostic without mutations. Her doctor recommended core needle biopsy, but the patient refused further evaluation. Later, she visited South Korea, and that was when I made my diagnosis. After I reviewed all prior ultrasound images, I asked her to undergo an esophagogram. The lesion was determined as an esophageal diverticulum. This patient underwent lobectomy due to microcarcinoma. 5 years later, a tiny metastasis was diagnosed at an outside clinic. When I did ultrasound on her neck, I could not find any suspicious features. As you know, lymph node metastases are very common in patients with even very small thyroid cancers. Although patients are commonly followed with ultrasound as seen in this case, ultrasound itself can also lead to unnecessary interventions, even in patients who have already undergone surgery for microcarcinomas. Despite the fact that many incredible researchers do not recommend screening ultrasound for the detection of thyroid nodules, many ultrasound exams are still being performed for that purpose. Therefore, we need to develop appropriate ultrasound risk stratification systems that also use appropriate FNA size thresholds. Most of us have probably experienced situations in which examinations are repeated after a thyroid nodule has been found because some doctors and patients don't want to chance missing anything, even if the detected nodule itself is not clinically meaningful. Today, even after a small cancer is excised, interventions are sometimes done for recurrences or persistencies that are likely to be clinically insignificant. This trend is something of concern and something that we need to resolve. Thyroid is the starting point of many interventions. With all the knowledge we have accumulated so far, we need to find a way to de-escalate the care management of thyroid nodules.